Hello, my name is Monika Sanghavi. I'm Assistant Professor of Medicine at the Perlman School of Medicine at the University of Pennsylvania. Welcome to CVI Heartbites. CVI Heartbites is a free, non-accredited educational program produced by the Cardiovascular Institute of Philadelphia, featuring succinct presentations delivered by leading experts on timely topics in cardiovascular medicine. This CVI Heartbite segment focuses on cardiovascular disease in the age of COVID-19, the role of ACE inhibitors and ARBs in COVID-19 patients. Please note this presentation was recorded on May 29th, 2020, and the information was up to date as of that time. At the end of my presentation, you will see some additional resources and have the opportunity to contact me with any questions you may have. What I want to talk to you today about are the origins of the controversy on RAS inhibition in COVID-19, current recommendations, recent data, and ongoing trials. The RAS inhibition in COVID controversy has two sides, and the concern with RAS inhibition is based on two main points that I'm going to discuss on this slide. On the left, I want to talk about the fact that SARS-CoV-2 enters the cell through the transmembrane protein ACE2, the transmembrane receptor ACE2. And the concern with this is the fact that with RAS inhibition in some animal models, we have seen an upregulation in ACE2 receptors, resulting in the speculation that with an increase in ACE2 receptors on the cell membrane, we might see an increased susceptibility to COVID-19 infection, as well as increased susceptibility to severe infection as well. This physiologic data, coupled with some epidemiologic data early from Wuhan, China, increased the concern. This data from Wuhan, China, looking at patients hospitalized at the two main hospitals, showed that the prevalence of risk factors in patients admitted with COVID-19 showed a high prevalence of hypertension, diabetes, and coronary artery disease, as well as an increase in mortality in these patients. Hypertension, diabetes, and coronary artery disease are all treated with RAS inhibitors. And the concern was that possibly the RAS inhibitors were what was increasing the susceptibility for these patients. In a very simplified pathway for angiotensin, I'm just going to explain the renin-angiotensin pathway in a very simplified diagram. Angiotensinogen is converted to angiotensin 1 by renin, and then angiotensin 1 is converted to angiotensin 2 by ACE, the ACE enzyme, which is blocked by ACE inhibitors. Angiotensin 2 is a potent vasoconstrictor, and ACE2 converts angiotensin 2 to angiotensin, which is actually a vasodilator. ACE2 has also many other effects that I'm not discussing in this slide. But the thought is that ACE2 can serve as a counter-regulatory mechanism for the RAS pathway and may actually have some benefit since it converts angiotensin 2 to angiotensin, which is a vasodilator. And this is where this other side of the controversy originates. There's some data to suggest, as you can see from this meta-analysis that was published in the British Medical Journal in 2012, that there is some evidence to suggest that there may be a protective role of ACE inhibitors in the risk of pneumonia. And interestingly, this protective effect was seen with ACE inhibitors, but not ARBs. And so this resulted in the other side of the controversy, with some suggesting that ACE inhibitors might be a treatment for COVID-19. This controversy gained a lot of traction in social media, as well as in the academic community. There were lots of statements being put out by different academic centers, as well as hospitals, on whether or not to stop RAS inhibitors in patients with COVID-19 or those at risk. Due to this significant controversy, the HFSA the ACC and the AHA came together to put out a joint statement on COVID-19 and RAS inhibition. And basically what they said was they recommended continuation of RAS antagonists for those patients prescribed these agents in systemic diseases where we know it's beneficial, such as heart failure, hypertension, and ischemic heart disease. We know that RAS inhibition is beneficial in these disease processes, and they acknowledge that we do not know whether it's beneficial or harmful in COVID-19. And they called for additional research on this topic. And we have seen several studies on this topic. Most notably were the 3 articles published on May 1st, 2020 in the New England Journal of Medicine on this topic. None of these are definitive answers to the question, but what makes this data powerful is that all 3 studies came out with the same conclusion despite using several different clinical designs and being done in several different populations. The first one that I want to talk to you about was done by Reynolds et al. In the NYU Langone Health System. And what they looked at were 12,000 patients who were tested for COVID, and about 47% of them were positive, and 17% had severe COVID disease, which was defined as an ICU admission, hospitalization, ICU admission, mechanical ventilation, or death. And they looked at 5 antihypertensive classes, including ACE, ARBs, beta blockers, calcium channel blockers, and thiazides. And what they found was no substantial increase in the likelihood of a positive test for COVID-19 or in the risk of severe COVID-19 disease among patients who tested positive, looking at all these 5 common classes of antihypertensive therapy. So they found no association. Secondly, I want to talk about this next study that was done in Lombardi, Italy, which is a hard-hit area in Italy. This study was a case control study looking at 6,000 cases and 6,200 cases and 30,000 controls in a 1:5 case to control ratio. And what they found was that although in unadjusted models, there was an association, when you adjusted for age and risk factors, there was no association between RAS inhibition or other antihypertensive medications, monotherapy or combination therapy, and the risk of developing COVID-19. This next study was actually an international study looking at 169 hospitals in Asia, Europe, and North America. 17% of the patients were from North America. This too was an observational study looking at 8,900 patients hospitalized for COVID-19, and they looked at the risk factors or for death. They did not see an increased risk of death in patients hospitalized for COVID-19 who were receiving ACE inhibitors or ARBs. Interestingly, they saw a possible benefit in patients receiving ACE inhibitors and the risk of death in COVID-19. This was not seen in patients taking ARB therapy. This should be hypothesis generating and should not change clinical practice, since this was a subgroup analysis, and we know that the authors were not able to account for or adjust for multiple comparisons. So this could just be a random finding. This last study that I want to mention is this study on that was done with 7 hospitals in Madrid, and it was a case control study as well, looking at 1,100 cases and 11,000 controls. This was published in Lancet 2 weeks later on May 14th. What they saw when they matched for age, sex, region in Madrid, and date of admission to the hospital, and their main analysis focused on the association between COVID-19 requiring admission to the hospital and use of RAS inhibitors. They tried to account for confounding by indication by comparing RAS inhibitors to other antihypertensive therapy, specifically calcium channel blockers. And what they saw was that there was no association with increased risk for hospitalization with COVID-19 in patients receiving RAS inhibition. In a subgroup analysis, they found that in patients with diabetes, there may have been a protective effect of RAS inhibitors, both ACE and ARBs, and the risk of hospitalization. Again, this is an observational study, and this is a subgroup analysis and should be hypothesis generating rather than changing clinical practice. So in summary, the current data available supports the AHA, ACC, and HFSA statement to continue RAS blockade in patients with COVID-19 or those at risk. The current data available does not suggest harm while taking RAS inhibition in COVID-19. There was no association with increased COVID positivity, no association with severity of disease, and no association with mortality. The possible benefit of ACE inhibitors over ARBs or RAS inhibition in diabetes is speculative and hypothesis generating and should not alter clinical practice. And to remind everyone that all the data we've seen thus far is really observational with limitations and possible residual confounding. There is an ongoing trial through Penn called the Replace COVID-19 study, looking at randomizing patients to elimination or continuation of RAS inhibition once they're hospitalized for COVID-19. This has expanded to become an international study, and we're hoping results from this and other randomized studies will provide definitive answers to this ongoing controversy in RAS inhibition in COVID-19. If you have any questions, please feel free to contact me at the email address below or contact CVI's Executive Director at the email provided. Please share this link with anyone you think might be interested in the information, and please let us know if there are any other topics of interest to you. Thank you for participating. Thank you for watching the CVI Heartbites segment. For more information on other CVI Heartbites segments, as well as CVI educational programs, please visit us at cviphiladelphia.org or follow us on Twitter at the handle and hashtag listed below.